Y'all got it? Y'all all right? Okay. All right, so you can see some of the key times to suction. I said it already, I'll say it again. First thing in the morning, right before bed, in between the day, blah, blah, blah. Now, you want to hyperoxygenate before and between and after suctioning. That is bullet point number 4 going up from the bottom. How many breaths with the ambu bag to hyperoxygenate? 3, that was on the chest. After you have suctioned your patient, increase the O2. Just turn it all the way up. Shit, fuck it. Give them what they need. And then you'll decrease it slowly but surely, but you do need to know to go up. This is tricky on the test. It is the last bullet point. There are 2 types of trachs, cuffed and uncuffed. You have to know that the cuff must be deflated for speech. So you see, deflate before suction and to allow for speech. And then of course the natural would be uncuffed, allows for speech automatically. Are you good? Okay. All right. Now, breathing treatments. Okay, let's talk shop, because once again, the shit is ridiculous. My girl took a little part-time, no, it was a PRN job. She's a med-surg nurse. She came up out of here years ago. She took a little PRN job at a nursing home. She said, why, Jesus, did I go work in this nursing home and think about how you used to tell us all the time that those patients ain't even getting their breathing treatments? Why did I do that? She said she went to go work at the nursing home and she's doing her little Nancy Nursey thing. And so she's coming around doing her breathing treatments. And one patient after another said, you must be new. That's the first time they do that. Wow, that's scary, because she said that every single patient's chart said that they'd had it. So we call that falsification of documents. And because the patient's on Medicare, that would be called a felony. Because fraud, when it affects a federal insurer, is felony. Now, I suggest, unless you want me to put money on your books, that you take your happy ass to that nursing home and actually do the breathing treatments, please. Because a real live patient, to tell somebody who actually reports it, and they come and find out that all the medicine was still in the canister, you never even got the canister, you never even got the actual refill, you didn't get nothing, the patient ain't never had a refill, been there 3 months, ain't never even had a refill, all this stuff that they can find out that you never did. Now I'm visiting you over there at Marysville Prison for Women, because you own some trash. So my suggestion to you is don't even go work there if you think you can't do your breathing treatments, because it's becoming very serious and they are sending you to jail instead of just writing you up. It's a jail thing now. So here we go. If you look at what I wrote, what does not giving them their breathing treatments do? What did I write? Number 1 cause for hospitalization is simply these patients never got their breathing treatments. It's very sad. This is why I will not put anybody I love in these homes. She was told she must be new because don't nobody ever do this. And that was the whole unit. Okay, play around if you want to. Next on the lineup, you want to teach new mothers who have to give breathing treatments to new babies that the more they cry, the better the treatment. Because it is scary for daddy. It is scary for mommy. It is scary for these precious people who have never done something like this in their life to try to do it on a screaming ballistic kid. They feel like they're torturing their child. They feel like the shittiest mom or dad in the universe. And you need to make them know It's okay, my love. The more they scream, the better the treatment, because every time they scream, they take a big, deep breath of the treatment. How do you know you did it long enough? Because the fluid, on the test, because the fluid is gone. How do you know the treatment was delivered effectively? Because the fluid in the canister is gone. That's a good one for y'all babies. Because if you're like me, breathing treatments, God, Jane gave one and God knows when. Now you gotta take a test about a breathing treatment? Oh my God. Okay, so that's how you know, y'all. Now, it's not gonna be called a breathing treatment on your test. What's it gonna be called? Nebulizer. Nebulizer, bronchodilator. Never is it going to be called a breathing treatment, ever. Okay, all right, guys. Chest physiotherapy. Understand who this is best done on. What did I put? Cystic fibrosis and COPD. Not the emphysema part of COPD, but the bronchitis part. Remember this, because some don't, and that is why I say it over and over again. COPD is an umbrella term that incorporates two conditions, bronchitis and emphysema. Chest physiotherapy is done on bronchitis, but not necessarily emphysema, because you can crack some ribs because they're super thin. So I want you to remember that COPD is just an umbrella term. It has two conditions up under the umbrella. Not everything for one is the same for the other. This is one of those things. Great for bronchitis, not the greatest for emphysema. It is absolutely great for chest, for cystic fibrosis. Maybe there's a condition that doesn't fit any of these and I didn't write it down. Like my student who had a baby, and that baby inside of her when she was pregnant, she didn't feel right about, because a mother's intuition is a very powerful thing. She told the nurse midwife no less than 3 times, I just don't think this baby is really moving that well. The midwives pretty much told her something along these lines. It's your first baby. You wouldn't know how it's supposed to move. It's perfectly fine. We see that it's moving. She's like, oh, I don't know. But this kid did something that was a little bit of a hint. When the baby is breech, sometimes it's completely innocent. Other times it's a sign of something worse to follow. When a baby is upside down or breech, sometimes it means they can't physically turn themselves with the heaviest part of their head to go head down. In the case of a Down syndrome baby, their head is smaller anyway, so it's not the heaviest part of their body, and it doesn't allow gravity to pull it down. So this kid didn't have Down syndrome, but little did she know it had a type of cerebral palsy for which we don't even know why that happened to her, because she had no trauma at birth or nothing. So here we are with this breech baby, scheduled C-section, cut the baby out, and it did not cry. And she never ever heard a cry because it never could cry. This baby didn't breathe, didn't cry, didn't cough, didn't even choke. So her baby was born with this weird syndrome that all the genetic testing pointed to. Nothing genetic here, just shit happens. Now, this is what she said, which is what you want to remember. She said they told her this baby will need, just like I wrote, just like she testified in class, just like I wrote, chest physiotherapy at least 5 times a day. First thing in the morning, last thing at night, and all in between the day. Y'all see that? Now, here's the problem. The chest physiotherapy that this child needed while in the hospital was delivered by this really cool vest. How many have seen the vibratory chest physiotherapy vest? It's the coolest thing. She brought it to school. She let everybody see how it works. You put it on this kiddo and it's doing it for you. There's just one problem. When they wrote for her to have the vest at home, it was $7,000 a week for rental. And insurance didn't cover it. Bless their hearts. Of course they didn't. That's why your test wants you to know how to do chest physiotherapy with your own hands. So what she said, and I quote, "The nurse was sent from heaven, and she taught me how to do chest physiotherapy so well that I felt strongly that it cleared my precious daughter's lungs better than that stupid vest." Now you gotta know. So let's go. Your hands must be cupped. They must be cupped just like this for the percussion part of this episode. The percussion part of chest physiotherapy, think about when you were in band and percussion meant like, banging on things, really, really cool stuff like that. You are banging on this kid's chest and you must hear it because, again, you're in band. So watch. Right over the lung that's most congested. How will you know? Because like I said on that paper, your first nursing action is to listen to the lungs first. Find out what part of your child's lungs is the most congested and then get to work. Vibratory is hard as hell to do. So you got two parts of chest physiotherapy. You got percussion and then you got the stupid vibratory. That is really hard to do. It go a little something like this. Your hand is over that child's chest and that other hand is on top of this hand and your arms are moving, but you're never lifting off the chest. See my arms? But the hands never came up, did they? That's vibratory. I know it sounds weird, but that shit clears this kid's lungs better than any vest does. So look what we got. Chest physiotherapy. Listen to the lungs first. Make sure you check them after. You see what it's for. You see right up under that it says postural drainage, percussion, vibration. I just showed you what it was. In my day, we called it pats and claps. Pats and claps. We didn't have vests in my day. I trained on a cystic fibrosis floor when I was in Ursuline College and nursing school, so I knew how to do pats and claps really well because that's all we did on that floor, okay? You guys don't probably get that sort of clinical experience, so you kind of get screwed and you got to kind of imagine, what does that look like? Okay, then, ooh, this is a good rule. It's capitalized in bold. Good lung down. Here's what I mean. I kind of showed you, but let's remind you. Your baby has, on the chest, a congested left upper lobe. What position do they need to be in when you get ready to do your chest physiotherapy? Yep. Good lung down. That is true for taking a lobectomy, so doing a surgery where you take a lobe of the lung out. Remember, don't position them on that. Position them on the good lung. That's true for pneumonia. If the x-ray shows right lower lobe pneumonia, good lung down, you got to position them on the left. Just keep saying to yourself, good lung down throughout the whole test. Gunshot wound on the left side, good lung down. Position them on the right. Whatever's happening, there's only one exception to the rule. And that is if you took the whole lung out. That's called a pneumonectomy. You took the entire lung out of the patient. You can't do good lung down because watch what happens when you do. If you take this entire lung out and you say, well, let's follow the rule and do good lung down. And you position them on this side. The blood from the surgical site is going to bleed and collapse this one. That's called a hemothorax, isn't it? Because it's heavy, blood's heavy. It's going to collapse that other lung. So the only exception to good lung down is no lung in it. So you just position them on the hole where you created this space, if you will, and there the blood will drain, but you already have a drain in the patient. So you're good, okay? I need y'all to know them kind of things. It's weird. Okay. Now, remember what we said. We said bullet point number 6. First thing in the morning, everybody see it? Between the meals and at night. Every 5 hours of so or so, but never when? That's on your test. Why not? Why can't I pat and clap your ass after you ate? You're gonna throw up. I'm putting you upside down, right side up, turning you around, spinning you down. I mean, if you saw the different positions for this, because you got a kid who's sitting up, then they laying back, then they on their right, then they on their left, and you're doing it every what? 15-minute position changes, which is what it says already. I know, child. That's how I feel. Ooh, boy. So you are changing positions every 10 to 15 minutes. You guys have come out of the test and said, oh, I have no idea what that word meant. And I understand, because this vocabulary is from another world. Look at that word, adventitious. That's not a good word. Adventitious means bad breath sounds. They use that word and throw you a curveball. Remember, it could be anything, but it's always bad. It could be wheezes, it could be rails, it could be stridor, it could be whatever. It's always bad. Okay, incentive spirometer, my favorite. Let's suck some balls. Right. What you say, girl? Okay, now, one of my favorite shows used to be Ellen. And one of her little celebrity friends had just had surgery. And let's just say he was a little Fruit Loopy, bless his heart. And so he was on her show having a good time, at least making me laugh my ass off. And he said, oh, Ellen, I've got a good one for you, girl. While I was in surgery, the nurses turned me on. They told me to suck the balls. She was like, no, they gave you permission to suck balls? He was like, yes. And she goes, what? He said, oh, see, there's your dirty mind. He pulled out one of these gadgets. And he said what I have told patients forever. Suck the ball. Here's why you give a shit that you're sucking and not blowing. You care to suck and not blow because if you blow, you did not help your patient. Now, y'all laughing because you think it's crazy funny. Let me tell you what I found. I walk in the postpartum room. The patient done had C-section after C-section after C-section. I walk in the room, and I decided to do this with every C-section patient to see if it's just like, you know, 1 or 2 people every now and then, or all the damn nurses. I walk in the room, I see this on the tray table. I said, oh, I'm so excited you have your incentive spirometer. Now let me ask you something. Did the nurses go over it with you? Half the people say no. The other half say, oh yeah, she told me I gotta do it every hour. Good, because that's on your test. So did she say how you do it? Yep, she showed me. She said you just blow into this little hole. Wow. Really? Is that what she said? And I mean, it's so easy. I don't know why people fight it, because it's kind of easy to blow into the hole. Nah, not so much. So here's the deal. Your nurse is really good, and I love her. She is a really sweet thing. But she got a little part of that wrong, dear heart. Let me show you how to use this. This was 90% of nurses, which is really disgusting. I said, let me show you how to use this. And y'all got to remember this, because if you teach it right, your patient going to be so healthy. When you suck this ball up, it's not enough to just suck it up. No, you got to keep it up, which is hard, for as long as you can. And it is not easy to do that. So when you do that, what did you just do? Oh, let me tell you what you just did. On the actual paper itself, I should have written it. Shame on me if I didn't. You'll tell me if I did. You are preventing atelectasis. Good, highlight it. What in God's name is atelectasis? It's collapse of the alveoli. Why do you give a shit if the alveoli collapse? Because the alveoli in your lungs is where the gas exchange takes place. And so if you collapse the alveoli, you can't get oxygen in and CO2 out. When you do that, you cause this patient to get a pneumonia or ARDS when they have had surgery. So when you do it correctly, you prevent atelectasis, you keep the alveoli open, you get the oxygen in, you get the CO2 out, and you create a situation where she's gonna be discharged in about 48 hours and feel really good about it. When you don't, you get pneumonia, period. That's why it's what? What do we tell you the second day or maybe the first? It's the fourth killer of post-op patients. And it really kills them if they also smoke. Okay? So you want to remember that with your incentive spirometer, there's lots of different ones, right guys? This is another one. It's still the same concept. You got to get this blue ball up and you got to keep it up. You don't blow into these things, but yet there's a million nurses that think that. Okay, there you go, baby. Now, here we go. If you remember the last part, you're doing good. The patient must be sitting straight up, and after they do it, they have to cough. So what'd you do? Cough and deep breathe. Oh, I'm so glad I thought of it. Here we go. Ooh-wee. Now this is an example of a very popular question. Okay, here we go. The nurse knows that the best way to prevent pneumonia in the post-op patient is what? Or they say immediate post-op patient is what? Now, again, the nurse understands that the best intervention for the immediate post-op patient to prevent pneumonia is what? Raise your hand if you want number one. Raise your hand if you want number two. Oh, I'm sorry. You're right. I got abbreviations. My bad. Cough and deep breathe. Incentive spirometer, you're 10 times an hour. Head of the bed up with semi-filers. Nasal cannula on at 2 liters per minute with continuous pulse ox. So we'll do it again. Who wants number one? Raise your hand. Who wants number two? Raise your hand. Who wants number three? Raise your hand. Who wants number four? Raise your hand. Okay, some punks didn't vote as usual. Here we go again. For this question, your money, not mine, I got paid. Number 1, cough and deep breathe. Raise your hand high. I'm gonna count your hands and we're going to kill you if you don't vote. 1, 2. Yes, what is the number 1 intervention to prevent pneumonia in the immediate post-op patient? Cough and deep breathe. Raise your hand if this is what you want. Raise it high so I can count your little baby hands. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Raise your hand if you'd like to do the incentive spirometer 10 times an hour like this thing says. 1, what are you doing? You scratching your eyeball or are you raising your hand? Are you doing this or not? Raise your hand. Keep it up, okay? Do me that favor. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, next. Head of the bed up, semi-foulers. 1, 2, 3. Next, nasal cannula on at 2 liters per minute with continuous pulse ox. Anybody? Okay, this is what I see all the time. This one is right. Now let's talk about why. My beautiful friend was in New Orleans during Katrina. She's a nurse midwife like me. Like me, she was closing up a patient, putting staples in the belly after a C-section. She's putting the staples in the belly of this patient following a C-section. Water is rising up her thighs as she's doing it. The helicopter is waiting on this patient. That patient's baby is on a whole nother helicopter, maybe in another state. ID bands, real important. Now, so we have this patient who is about to be life flighted to another state as catastrophe abounds in New Orleans during Katrina with water up your ass. She knows that the most important thing she can get this nurse to remember on this helicopter is not my friend, the nurse midwife, leaving the OR, going to Central Supply, grabbing an incentive spirometer and giving it to her. No, because on this test, they want to know that the right answer is just in case you can't get the gadget. Boom. Her number 1 thing to tell the nurse receiving this immediate post-op patient, please tell her to cough and deep breathe. Please tell her to cough and deep breathe. Remember to tell her to cough and deep breathe, because you know how it is. We ain't got shit. No incentive spirometers, nothing. Please remind her to cough and deep breathe. You got to think like the test, baby. Okay? You got to think this is what you can do without any gadget. Y'all feeling me? It's kind of like that vibratory vest. Pats and claps. No technology. Electricity out. Insurance didn't cover it. Y'all feeling me? Okay, y'all. Now, so the answer is always cough and deep breathe if it's ever part of the option. It's kind of like hand washing. It's always the answer. When are you not hand washing? Who does that? So hand washing, always part of the answer. Cough and deep breathe, always part of the answer, except cabbage patients. Except ICP patient. Why not ICP?
Agitates that you don't want to.
It's going to raise the intracranial pressure, right? Your cabbage has to be medicated first, that's all. Okay? Before you cough anything out of them. Okay? Okay, y'all got this. Next page. Okay. Now we on page 7. Pursed lip breathing is kind of easy. I do not need to teach you that shit, but what I do need to tell you is something that's confusing. Your test wants to be obnoxious, and what they did was say that you are ambulating the patient, teaching them pursed lip breathing when you ambulate the patient. So I put that in the last bullet point, because here's what you're gonna find. When you do pursed lip breathing, you got to kind of think scientifically. So let's remember, inhale in your nose. I'll do it in front of you. Breathe out through pursed lips. Which one was longer? Yes. Now, what did I just breathe out? You got this. Now, so if I got rid of my CO2, the pursed lip breathing that I'm doing is preventing acidosis, isn't it? Because what did we say yesterday? CO2 is an acid. If I don't get it out, I'm going to cause acidosis. So I teach patients at risk for acidosis to do pursed lip breathing. And the way the ambulation part goes, because you're going to think it through, that's why you sit on your hands and don't answer quickly. You're going to think it through. They're going to say you're ambulating a patient. What should you tell the patient to do with their steps in relationship to their breathing? So 1, 2, what does it say on point number 4?
Exhale, 1 6 steps.
Yes, did you see that? So you saw it, right? You saw that the first 2 steps, because again, the exhale must be really long. So the first 2 is just 2 steps. You went, and then you went. It sounds so crazy the way they write it on this test, but you just saw me do it, so you gonna be fine, LPN. That's on your test, okay? In other words, they know you get the COPD patients. They know it. And they want to see if you understand when you're ambulating with this patient, teaching them pursed lip breathing during that time, that they take in the breath on the first 2 steps, they let out the breath on the next 4 to 6 steps. Because your exhale must be longer than your inhale if you're really getting rid of excess CO2. So far, so good? All right, let's go. O2 therapy. What do you got to know about that? Well, you have to know that this non-rebreather mask that Sister Girl has on, so find your notes about non-rebreathers. Y'all see it? This bag must be inflated. You can't just go slapping the patient upside their face with this mask. You must inflate this bag first. This non-rebreather mask, and it does look like this non-rebreather mask is never kept in the room. You actually have to leave your room, go where respiratory therapy equipment is, and grab yourself one for, what did we say? Respiratory distress. If you're the only one in the room, you ain't leaving that room. We said the other day, don't leave your patient. Call out on the boat, Sarah, I need a non-rebreather mask in room, whatever. Okay, you feeling me on that? So this mask, why is it called a non-rebreather, Shelly? Oh, thought you never asked. Here we go. This one's broken. Probably the dog got it. My dog is crazy. This one is intact. Do you see the flippy floppy thing on this thing, which is really tiny holes? It's on both sides, but Biscuit no doubt got that one. But usually it's on both sides. This is inflated with oxygen. You then put this over your patient's face, and when they take a deep breath in, they get a bag full of good O2, don't they? Now, the problem is when they breathe out. What do you breathe out? Does true respiratory distress need to breathe any of that back in? So we want them not to breathe it back in, so we need a non-rebreather. So what happens when they breathe out? These flaps allow it to open up and let the CO2 out, and then as soon as you breathe in, they close up all these holes, and all you got is oxygen. You have a non-rebreather mask. You don't need any more CO2 because we already established you're in distress. So you have too much CO2 retention. So that's how this works. Does that help you guys when we say these fancy dancy $4 words like non-rebreather? What the fuck is that? That's what it is. Okay? Now, again, precious one, I've had to tell the nurses, it's not in your room, sweetheart. You're going to have to call out for one like yesterday. Or let me just go get it, because I'm training you, but, I'm your girl. I'll go get it. So that's how you do it. Now, the simple mask. Find that on your paper. The simple face mask. Did you find it?
Yeah.
Okay, that's the one in every single room already. That's a great mask, but which one gives you 100% O2? The non-rebreather. What percentage does a simple mask give you? Oh my God, that's okay to get started, but is that enough for true distress? No, but it is good until I can get that mask. Now, let's go a little back further, honey. Nasal cannula. Oh, Lord. What percentage of oxygen is that? Oh my God, so let's just do the damn thing. Right now, we're in this room together. Guess what? We are breathing 21% oxygen. What the fuck is 25% gonna do? Y'all see what I mean now, don't you? In other words, don't reach for a nasal cannula in true, full respiratory distress. You look crazy. You look like you are really a high school dropout and imitating a nurse. Do not reach for a nasal cannula in true, full-blown respiratory distress. You feeling me on that? They're going to kick you out as soon as they can. Now, here's our thing. We got another problem with our nasal cannula. Had to tell the nurse this the other day. So you got the patient, they're in for an EGD, they've got the scope in, you've given your little sedation drugs, you notice the pulse ox is dropping, they already have their nasal cannula on, then the scope comes out, they're not coming up in their pulse ox, they're not really even alert enough to do what? Cough and deep breathe. So now she takes the oxygen that is on the 2 liters and she spins that bad boy all the way up to 10. Is that doing anything?
No.
What's the limit? 6 is on your test. The limit is 6. Once you go past 6, you're humoring yourself. You ain't doing shit for the patient. You're just making yourself feel better, baby. You ain't doing enough for that patient because you can't do anything above 6 with the nasal. Okay, it's a teeny weeny little thing, y'all. Okay, so these are things that good nurses understand. If they don't, they learn it that day because it didn't do shit. Sure as shit, it didn't do nothing. Okay, and we did end up getting a non-rebreather, which does give 100%. We ended up doing that. We tried the mask, it didn't do shit either. So we ended up pulling that non-rebreather. Does that make sense now? See, you gotta kind of know how to step it up. All right, now, our patient is quite different with a Venturi mask. And yeah, they like that one too. The Venturi mask is for the COPD patient who needs precise low amounts, 2 liters, 3 liters, that's it. 3.8, 2.7. Tiny little precise amounts, and it is different colors. It's like all kinds of cute different colors that you can change it up to give that precise tiny amount. That's as exciting as it gets. You don't have to go too much crazier into your different masks. One mask that we no longer use, you might as well just scratch it off, is the partial rebreather. Cross it off. Now, I do want to say this about these whole mask things. When it comes to the mask, when we talk about a rebreather, I need y'all real smart. I said it the other day, but you know how it is. You get so much stuff in this class, you lose half of it because it's so much. But so I'm gonna say it again because so many people suffer from it. And I mean, I've had a million asthma attacks in this class. My grandson got it. It just is what it is. So when it comes to asthma, is that patient at risk for respiratory acidosis or respiratory alkalosis? I'll go around. What do you think, honey? Alkalosis or acidosis? Already respiratory. So which one you want?
I would say acidosis.
That's the first one.
What do you think, honey?
Unsure.
You don't get to say that in my class. It says you have to try.
Asthma.
Asthma, what are they at risk for? Respiratory acidosis or alkalosis when they're having an asthma attack?
Acidosis.
Okay.
Hey, acidosis.
Respiratory.
I didn't hear you.
Acidosis.
Acidosis, both bacteria.
Acidosis.
Acidosis, that's a different word. I ain't mad at you, girl. Acidosis, okay. Acidosis? Alkalosis? Alkalosis? You said alkalosis? You said acidosis? Okay, so this is really hard because, you know, you're thinking it's a respiratory condition, and most severe respiratory conditions would be, you know, easy. It's like, okay, they'd be acidotic. There are two serious respiratory conditions that don't fit that mode. Asthma attacks and pulmonary embolisms do not follow the rules. They are not acidosis, they're alkalosis. And here's the reason why. Because when you have an asthma attack, just like my grandson, just like the 2, 3, 4 people this year in my class, because it'd be a lot all the time, just like a PE, that patient is struggling to breathe. So there is anxiety in there. There is a little bit of hyperventilation in there. There is like a little bit of panic in there. Y'all feeling me? So that, and what are they doing also? Right? They doing it just like that, right? And every time they coughing, what they getting rid of? Acid. What's left? Alkalosis. So they're actually, and yes, you have to know this, they are actually respiratory alkalosis because it's a little bit of anxiety, panic, and struggling to breathe caught up in there. It didn't gradually happen usually. It kind of just hit, okay? So when we say that that's what's going on, and then we look and we say, okay, this patient is having all of this trouble with basically having alkalosis. If we ignored them and did nothing and they went on like that for hours, oh, you could flip it then. Then we're gonna be in trouble. We're gonna be all the way acidotic. But your test doesn't deal with you ignoring them. Of course not. You're the nurse. You're not ignoring them, you're treating them. And you must remember when you get this patient, they are in full-blown respiratory alkalosis. They're gonna need blood gases, aren't they? Now, here's what I wrote. If you go to the top of page 7, it says ABGs. Does everybody see that? Top of page 7, third one, bold print.